Arterial pressure monitoring. Arterial catheters provide direct arterial pressure monitoring. Provide continuous measurement of systolic, diastolic, and mean arterial pressures and allows for arterial blood sampling. It's generally more accurate than indirect methods like non-invasive BP cuff monitoring, which are based on blood flow. It permits detection of hypotension earlier than indirect monitoring techniques. Arterial pressure monitoring is used in critical care settings. Catheter insertion, which can be performed at the bedside under surgically sterile conditions, is performed by a practitioner. The catheter should be removed as soon as possible to decrease the risk of complications. Indications. Frequent blood pressure measurements are required, such as for patients with low cardiac output and high SVR. Induced, ongoing or anticipated hypotension, or wide variations in blood pressure, patients who are obese or have severe edema. The need for frequent or multiple blood gas measurements. Need for continuous monitoring of cardiac output and stroke volume. Contraindications. Catheterization should be avoided in smaller end arteries with inadequate collateral blood flow. To prevent ischemia, invasive monitoring should also be avoided in extremities with suspected or pre-existing vascular insufficiency. Understanding an arterial waveform. Normal arterial blood pressure produces a characteristic waveform, representing ventricular systole and diastole. The waveform has 5 distinct components: the anacrotic limb, the systolic peak, the dicrotic limb, the dicrotic notch, and end diastole. Anacrotic limb marks the waveform's initial upstroke, which results as blood is rapidly ejected from the ventricle through the open aortic valve into the aorta. This rapid ejection causes a sharp rise in arterial pressure, which appears as the waveform's highest point, called the systolic peak. As blood continues into the peripheral vessels, arterial pressure falls, and the waveform begins a downward trend. This part is called the dicrotic limb. This event appears as a small notch, called the dicrotic notch. Equipment. Gloves, cap, gown, mask, protective eyewear, sterile gloves. 16G to 20G catheter. The type and length depend on the patient's size and the insertion site, with a 20G catheter preferred for the radial artery site. Pre-assembled preparation kit, if available. Sterile drapes. Fluid impermeable pad. Antiseptic solution, chlorhexidine, preferred, or tincture of iodine, povidone iodine, or 70% alcohol. Prepared pressure transducer system. Ordered local anesthetic. Catheter securement device or sutures. Syringe and 21 gauze to 25 gauze needle. IV pole tubing and labels. Site care kit. Padded arm board or limb splint. Leveling device. Stethoscope and blood pressure cuff. Portable ultrasound device. Sterile probe cover, sterile ultrasound gel. Sterile tape. Soft limb restraint. Sterile occlusive dressing. Hypoallergenic tape. Preparation of equipment. Perform hand hygiene. Set up and prime the monitoring system. Transducer system setup. Use a closed flush system to maintain patency of the pressure monitoring catheters. Make sure you keep all parts of the pressure monitoring system. Inserting a catheter. Perform hand hygiene. Position the patient for easy access to the catheter insertion site. Place a fluid impermeable pad under the site. Obtain baseline data, including vital signs, level of consciousness, and hemodynamic parameters, to help identify acute changes. Make sure that informed consent has been obtained and is documented in the patient's medical record. If the catheter will be inserted in the radial artery, perform an Allen test to assess collateral circulation in the hand. If the intended site is visibly soiled, clean the area with soap and water before the practitioner prepares to site with antiseptic solution. Then removes your gloves, perform hand hygiene, and put on a new pair of gloves. Using a pre-assembled preparation kit, the practitioner prepares and anesthetizes the insertion site. He cleans the area with chlorhexidine, allows it to dry, and then covers the surrounding area with a small, sterile fenestrated drape. The practitioner may use an ultrasound device with a sterile probe cover to locate the artery before insertion. The practitioner then inserts the catheter into the artery and attaches the catheter to the fluid-filled transducer tubing. During insertion, you may be required to assist with immobilizing the extremity and preparing the skin. While the practitioner holds the catheter in place, activate the fast flush release to flush blood from the catheter. The practitioner may suture the catheter in place, or secure it with a securement device. Cover the insertion site with a sterile occlusive dressing. Immobilize the insertion site. With a radial or brachial site, use a padded arm board or limb splint that supports flexion of the joint to maintain a functional position. With a femoral site, maintain the patient on bed rest, with the head of the bed raised no more than 30 degrees to prevent the catheter from kinking. Level the zeroing stopcock of the transducer with the phlebostatic axis, because the phlebostatic axis reflects central arterial pressure. Zero the system to atmospheric pressure to prepare the monitoring system for accurate arterial pressure monitoring. Obtain a manual blood pressure measurement and compare it with arterial blood pressure. Activate the monitor alarms as appropriate. Remove and discard your personal protective equipment. Perform hand hygiene. Run a waveform strip and document baseline data. Document the procedure. Special considerations. Be aware that several factors can lead to incorrect pressure readings, including a clotted catheter, loose connections, the addition of extra stopcocks or extension tubing, inadvertent entry of air into the system, and improper calibrating, leveling, or zeroing of the monitoring system. Regularly assess the amount of flush solution in the bag, and maintain 300 mm of mercury of pressure in the pressure bag. Replace disposable or reusable transducers at 96-hour intervals. Routine site care and dressing changes aren't performed unless the dressing is soiled or no longer intact. Regularly assess the site for signs of infection, such as redness and swelling. Notify the practitioner immediately if you note such signs. Using normal saline solution instead of a heparinized solution to flush the arterial line to reduce the risk of medication errors associated with heparin, a high alert medication.